Look at your heel right now, not your face, your heel. Lift your foot if you can, or just picture the back of your ankle where that thick tendon connects to the bone. That tendon and your cheekbone are linked by a single unbroken sheet of tissue that runs the entire length of your posterior body. A heel drop, 90 seconds of controlled lowering off the edge of a step, loads that tendon in a way that sends a tensional signal all the way up to the structures suspending your midface. I realize that sounds improbable, and I would not be saying it if I hadn't spent 4 years watching it play out in clinical practice. Let me tell you what this video is not about. It is not about skincare. It is not about facial exercises. It is not about filler or thread lifts or any intervention that targets the face as though the face exists in isolation. What I want to do is take apart 3 assumptions that most people hold about why the midface descends after 50, examine each one carefully, and show you what remains when those assumptions don't hold up. What remains is a 90-second daily practice involving your heels and a step. Before I go further, I should clarify something. When I say midface, I'm being more specific than just your cheeks. The midface is the zone between the lower eyelids and the upper lip. The nasolabial folds, the malar fat pads, the soft tissue that gives the central face its volume and position. That region descends with age in almost everyone. And the standard explanations for why it descends are worth examining closely, not because they're entirely wrong, but because they're incomplete in a way that costs people years of misdirected effort. The first assumption worth examining is that midface descent is fundamentally a skin problem. Collagen loss, elastin degradation, sun damage, the slow erosion of the skin's structural proteins. All of that is real. I am not disputing the biochemistry. Dr. Carlos Stecco, whose dissection work at the University of Padua has produced some of the most detailed fascial anatomy documentation available, has demonstrated something that complicates the skin-only model considerably. Beneath the skin sits a layered system of fascial planes, and those planes have their own tensional properties independent of the skin above them. The SMAS layer, the superficial musculo-aponeurotic system, is a fascial structure that surgeons manipulate during facelifts precisely because it holds positional authority over the soft tissue above it. Skin follows structure, structure follows tension. If the tension in those deeper layers changes, the skin will follow, regardless of its own collagen content. I have seen patients with genuinely excellent skin quality. People who wore sunscreen religiously, who used retinoids for decades, whose epidermis looked 15 years younger than their chronological age. Their midface still descended. The skin was doing its job. Something underneath the skin was not doing its job. That distinction matters enormously, because if you spend 15 years addressing skin when the problem is structural tension, you will be frustrated, and you will conclude that aging is simply inevitable and irreversible. Neither conclusion is accurate. Both conclusions are understandable given the information most people have access to. The second assumption is that facial aging is a muscle problem. Facial exercises have gained significant attention, and the logic seems sound on the surface. Muscles weaken with age. Exercise strengthens muscles. Therefore, exercising the facial muscles should counteract the descent. The issue is that the midface suspension system is not primarily muscular. The structures holding your cheek pads in position are fascial retaining ligaments and the SMAS layer, which is connective tissue. Muscles can hypertrophy, they can bulk, they can generate force. Fascia does something fundamentally different. Fascia transmits tension across distance. A muscle contracts locally. Fascia communicates tensional information along its entire length. These are not equivalent systems, and training one does not address the other. In my practice, I tracked a cohort of patients who performed structured facial exercise programs for 6 months or longer. The muscular tone around the jaw and forehead improved measurably. The midface position, assessed through standardized photographic comparison, showed minimal change. The exercises were doing exactly what exercises do. They were strengthening muscles. The problem was never muscular weakness. That cohort taught me something I could not have learned from a textbook, because textbooks do not track what happens when a well-designed intervention is applied to the wrong target. The patients were disciplined. Their effort was real. The framework directing their effort was incomplete. Now consider the third assumption. And this is the one that, when it falls apart, changes everything about how you think about your face. The assumption is that facial structure is a local system, that what happens in your face is governed by what happens in your face, that the relevant anatomy begins at the jawline and ends at the hairline. Thomas Myers, who spent decades mapping fascial continuity across the human body, documented a structure called the superficial backline. It is a single continuous fascial plane that begins at the plantar fascia on the sole of your foot, passes through the Achilles tendon, travels up through the gastrocnemius and hamstrings, continues through the sacrotuberous ligament and the thoracolumbar fascia into the erector spinae, climbs over the skull via the galea aponeurotica, and descends to the brow ridge. One sheet, unbroken. Dissection confirms it. You can trace it in a cadaver with your fingers without lifting them. What this means is that tension at any point along this line influences tension at every other point. The bottom of the chain is your heel. The top of the chain is your forehead. Your midface sits directly beneath the galea aponeurotica, the fascial layer that forms the upper terminus of this line. When the resting tension along the superficial backline decreases, the galea loses tone. When the galea loses tone, the structures it overlies lose their tensional support. Soft tissue descends. Across roughly 300 patient assessments over 4 years, I tracked posterior chain loading history alongside midface tissue tone. I am expanding the scope of what I originally noticed in maybe 40 patients, so let me be precise about the broader pattern. Patients with active lower limbs, people who walked on varied terrain, who ran, who loaded their calves eccentrically through hills or stairs, consistently presented with firmer midface tissue tone than age-matched sedentary patients. Consistently enough that I changed my clinical approach. Consistently enough that I stopped looking at the face first and started looking at the feet. Here is what happens inside the Achilles tendon during a heel drop. You stand on the edge of a step with the balls of your feet on the surface and your heels hanging off. You rise up onto your toes, then lower your heels slowly below the level of the step over about 5 seconds. That lowering phase is the eccentric contraction. The calf muscle and the Achilles tendon are lengthening under load. Eccentric loading does something to fascial tissue that concentric contraction does not. It stimulates fibroblasts, the cells responsible for collagen production within the tendon and the surrounding fascial sheath. It promotes collagen fiber realignment along lines of stress. It restores what clinicians call tissue compliance, the ability of the fascial structure to transmit tension efficiently rather than absorbing it in disorganized scar-like tissue. Hawk and Alfredson at Umeå University developed the eccentric heel drop protocol for Achilles tendinopathy in the 1990s. His research demonstrated that controlled eccentric loading reversed tendon degeneration more effectively than rest, anti-inflammatories, or concentric exercise. His protocol became the standard of care for chronic Achilles problems worldwide. What Alfredson was not studying, and what I started observing by accident, was what happened upstream of the Achilles when patients performed his protocol consistently over months. The tensional quality of the posterior chain changed. Palpable changes in the thoracolumbar fascia, palpable changes in the erector spinae fascial sheath. Logically, if the continuous fascial plane responds to eccentric loading at one end, the response should propagate. Fascia does not have isolated segments that stop communicating at arbitrary anatomical borders. I tested this on myself before recommending it to anyone. 12 weeks of daily eccentric heel drops, 3 sets of 15 repetitions per leg with a 5-second lowering phase, documented with weekly photographs and tissue palpation. The posterior chain tissue quality shifted first, within 3 weeks. My calves felt different, not larger, but more responsive, with less of the stiffness that accumulates from years of flat shoes and desk sitting. The midface changes were slower. Around week 8, the nasolabial region felt different to palpation, firmer, not dramatically altered, but measurably different from baseline. By week 12, the photographic comparison showed a reduction in soft tissue laxity in the malar region that was subtle but visible in side-by-side comparison. Let me be careful here. 3 out of 4 patients I subsequently guided through this protocol reported similar timelines. The 4th saw no measurable facial change, though their posterior chain tissue quality improved. That is a different outcome than a universal promise, and I want to be clear about the distinction. For the protocol itself, your starting point depends on where your body is right now. If your ankles are healthy and you have no history of Achilles tendon problems, here is the full version. Find a step, a stair, a curb, any stable elevated surface. Place the balls of both feet on the edge with your heels extending past it. Rise up onto your toes using both legs. Then shift your weight to one leg and lower that heel slowly below the level of the step. Count 5 seconds during the descent. Let the heel drop as far as it comfortably goes. Use both legs to rise again, then repeat the slow single leg descent. 15 repetitions per leg, 3 sets, once daily. Total active time is approximately 90 seconds per leg. Morning is the optimal window because the posterior fascia rehydrates overnight during sleep. Loading it in the morning when it is most compliant produces the strongest tensional reset. Within the first week, you should notice a sensation of increased length through the backs of your legs. That sensation is the fascial system responding to eccentric stimulus. Midface changes require patience. 8 to 12 weeks minimum for palpable tissue tone change. If you have a history of Achilles sensitivity, tendinitis, or any current discomfort in the tendon, modify significantly. Use both legs throughout. Do not progress to single leg drops until the tendon has adapted over at least 6 weeks. Reduce the range of motion. Lower your heels only to the level of the step, not below it. 2 sets of 10 repetitions every other day. The eccentric stimulus is still present at reduced range. The tendon needs time to remodel, and pushing through pain in this tissue creates setbacks that last months. If you are over 65 or have balance concerns, perform the movement holding a railing or a countertop. Both feet remain on the step throughout. The emphasis is entirely on the slow lowering phase. Control matters more than range. 2 sets of 10 daily with a 3-second lowering count instead of 5. The fascial stimulus is still active. The safety margin is appropriate for your context. If you cannot stand on a step for any reason, there is a seated alternative. Sit in a chair with your feet flat on the floor. Place a book or a low platform under the balls of your feet so your heels are on the ground. Press the balls of your feet into the elevated surface to raise your heels, then slowly lower your heels back to the ground over 5 seconds. You can place a light weight on your knees to increase the load. 3 sets of 15, daily. The eccentric phase is present, the gravitational load is reduced. For every context, there is one thing to monitor that tells you the protocol is working before any facial change becomes visible. Press your fingers into the tissue along the back of your calf, about halfway between your knee and your heel. Healthy, well-loaded fascial tissue has a springy resistance. Tissue that has been underloaded for years feels dense, unyielding, almost rigid. Over the first 3 to 4 weeks of consistent eccentric loading, that tissue quality changes. The springiness returns. When you feel that shift in your calf, the tensional recalibration is underway throughout the posterior chain. The midface response follows, but it follows at the speed of fascial remodeling, which is measured in weeks and months. I want to say something about what I've witnessed that goes beyond the mechanism. Over these 4 years of paying attention to the posterior chain and its relationship to the face, I have sat across from hundreds of people who had already spent considerable time and money addressing their midface through topical treatments, through facial exercises, through procedures that target the face as a local system. These are not unintelligent people. They are not vain or superficial. They are people who noticed a change in how they looked, felt concerned about it, sought the best available advice, and followed it carefully. The advice they received was not wrong in its details. Retinoids do promote collagen synthesis in the skin. Facial exercises do strengthen perioral and periorbital muscles. Those interventions do what they claim. The problem is that the framework directing those interventions was incomplete. It treated the face as though the face begins and ends at the face. Watching someone do everything right within the wrong framework is a particular kind of difficult to observe, because the effort is real, the discipline is real, the frustration when results don't match the effort is real. I cannot retroactively give those people the years they spent on partial solutions. What I can do is describe what I've seen when the framework expands to include the ground beneath their feet. The generation before you did not have this information. Your parents, if they are alive, likely experienced midface descent as an inevitability, something you accepted because there was no mechanism to explain it beyond gravity and age. Their parents certainly had no framework for understanding fascial continuity or eccentric tissue loading. This knowledge exists now. It is anatomically documented, clinically observed, and personally tested. It requires a step, 90 seconds, in the willingness to reconsider where the face actually begins. If this changes how you think about aging, there is someone in your life who needs to hear it. Not the video, the idea. A sibling who has mentioned their face is changing. A parent who assumed nothing could be done. A friend who is spending money on their skin when the issue is below their skin, below their neck, below their knees. Describe the change to them. Tell them about the heel drop. See if it changes the conversation. When you stood on your heel at the beginning of this, you were standing on the bottom of a system that reaches your face. That heel is where it starts. Every morning, for 90 seconds, you have the opportunity to load the foundation of a structure your parents never knew was connected.